Hello, my name is Mikhail Kirov, and the topic of my presentation is perioperative strategies for cardiac protection. I represent Northern State Medical University from Arkhangelsk, Russian Federation. It is in the north of Russia. Here we see my city, my university, and also I would like to declare that I have no conflict of interest for this report. From the current literature, we see that cardiovascular diseases still remain the leading cause of mortality. More than 30% of perioperative patients have these diseases. Perioperatively, we can see different hemodynamic disorders, from arterial hypertension and hypotension to arrhythmia, hypovolemia, vasodilation, decompensation of heart failure, and myocardial infarction. Thus, according to the results of recent studies in this field, like ISOS study, we see that cardiac complications are accompanied by a higher mortality rate and are among the main causes of perioperative morbidity. Myocardial infarction and ischemia reperfusion injury are among the most frequent causes of cardiac complications, and their mechanisms include oxidative stress, calcium overload, rapid restoration of physiological pH during reperfusion that will lead to opening of the mitochondrial permeability transition pore. And here in the left panel, you see that during ischemia, the anaerobic glycolysis leads to deterioration of pump transport, to calcium overload, and to acidosis. However, on the right panel, you see that during the restoration of perfusion, the lactate washout and normalization of pH are still accompanied by calcium overload and reactive oxygen species increase. That will lead to activation of mitochondrial pores, prolonged opening, swelling of cells, disruption of membrane of mitochondria, and to cell death. Thus, the strongest cardioprotective mechanism is to reduce ischemic reperfusion injury during conditioning. Conditioning can be both non-pharmacological and pharmacological. The non-pharmacological methods include ischemic conditioning directly at the heart level during short occlusion of coronary arteries for several minutes, followed by reperfusion. And since the direct ischemic conditioning has a limited clinical relevance, the remote ischemic conditioning is more widespread. It is caused by a temporary inflation of blood pressure cuff, causing limb ischemia with subsequent reperfusion. The pharmacological methods of conditioning include administration of volatile anesthetics, noble gases, alpha-2 agonists, propofol, opioids, phosphodiesterase inhibitors, and a number of other pharmacological agents. They can be administered both before ischemia, demonstrating preconditioning, during ischemia, perconditioning, or after ischemia, postconditioning. The main signaling pathways of conditioning include risk, reperfusion injury salvage kinase, and safe survivor activating factor enhancement. These pathways will activate nitric oxide synthesis and protein kinases, as well as microRNAs, leading to opening of mitochondrial potassium channels and inhibition of the mitochondrial pores. Here you see that acting through different pathways, both non-pharmacological and pharmacological methods will prepare myocardium to hypoxia, making it more resistant to hypoxic stress. Here you see that the risk pathway includes different kinases, nitric oxide, and actually will inhibit opening of mitochondrial pores. And the safe pathway will be accompanied by the activation of TNF and Janus kinases, also leading to mitochondrial modulation. Some agents, like propofol, have contradictory effects. On one side, it can inhibit reactive oxygen species, but on the other hand, by this mechanism, it suppresses the protective effects of volatile agents. Thus, also, as it has been shown, desflurane, sevoflurane, and isflurane can be preferable in cardiac injury during cardiac surgery, but the definite evidence for these agents for improvement of clinical outcome is still lacking. Here you see that the ischemic preconditioning also is unequivocal. It can reduce the release of troponins, but has no clear clinical evidence to improve outcome, as well as many other agents, from volatile anesthetics to cyclosporine, nitric oxide, clonidine, and some of these agents like beta blockers can have some beneficial effects for reduction of myocardial infarction size. Thus, the challenges of cardiac conditioning include the difficulty to translate the results of experimental models to clinical practice. The patients are different according to their age, comorbidities, medications. The myocardial injury is also different during myocardial infarction, cardiac and non-cardiac surgery, during on-pump and off-pump surgery. Thus, the future directions of conditioning include combining different strategies, targeting different pathways, and adequate study planning. Also, to counteract hemodynamic disorders, we have to detect them properly. For these purposes, we can use perioperative monitoring from non-invasive to invasive one, both with Doppler or pulse wave analysis, or even with thermoillusion techniques in the most complicated cases. In reviews devoted to hemodynamic monitoring and in our recent book on monitoring, we see that the level of monitoring depends on the risk of surgery and on the risk from the patients, changing from non-invasive strategies in low-risk patients to invasive blood pressure monitoring in medium-risk patients and even monitoring of cardiac output in high-risk patients. These issues are summarized in our review on perioperative hemodynamic optimization. When followed by monitoring, we can detect the disorders of oxygen delivery and improve oxygenation, correct anemia, and modulate cardiovascular performance by acting on contractility preload and afterload. However, the optimization of oxygen consumption is a more challenging task that is not easy to perform in many cases. For perioperative hemodynamic optimization, we can use different parameters based on Doppler, like flow time in this case, or pulse wave analysis, like pulse pressure variations, cardiac index, and mean arterial pressure as orienters for fluid inotrope or vasopressor therapy. In this multicentric study, we have shown that these goal-directed strategy can be accompanied by decreased number of complications. In cardiac surgery, the hemodynamic therapy can be even more complex, including both pulmonary pressures, volumes, cardiac index, and parameters of oxygen transport, including blood gases from arterial and venous blood. It has been shown that for hemodynamic optimization, we can employ even closed-loop systems. This is an example of such a system that can correct hypovolemia, for example, by infusion boluses through the feedback system. However, these systems are still under investigations. The perioperative hemodynamic monitoring and optimization can facilitate early detection of hemodynamic changes. They can be helpful to guide fluid and inotrope therapy, and combined with optimization can protect against complications, decrease hospital costs, and may be strongly encouraged, particularly in high-risk surgical patients, to improve clinical outcome. The new techniques and protocols require new studies, and some of the protocols do not facilitate early hemodynamic stabilization, like this study when administration of colloids did not lead to improvement of stroke volume. I conclude that there is a variety of non-pharmacological and pharmacological approaches for perioperative cardiac protection. The results of these approaches are contradictory. Evidence-based perioperative treatment protocols based on monitored hemodynamics can improve patient outcome, and further studies of cardiac protection are warranted. Thus, to protect heart during anesthesia, we should keep in mind patients' comorbidities, hemodynamics, conditioning effects, and build up our therapy to improve clinical outcome. Thank you so much for your attention.